good evening to everyone. I bring greetings from Christian Medical College and Hospital, Ludhiana, a glorious legacy of treatment, research, and education since 1894. So our journey today would be an introduction to ALS, goals of palliative care in ALS, timing of palliative care, symptom management, respiratory support, the communication challenges, the need for nutrition and hydration, psychological and emotional support, advanced care planning, end-of-life care, the multidisciplinary team approach, challenges and barriers in palliative care, and then we will conclude. So coming to ALS and palliative care, we all know that ALS is a progressive neurodegenerative disorder which affects the motor neurons in brain and the spinal cord, leading to muscle weakness, paralysis, and even eventually respiratory failure. So far, there is no known cure for this condition with a median survival of 2 to 5 years. Now, what is palliative care? Palliative care is derived from the word pallium, which means to clothe, to cover the symptoms. So it is an approach that improves the quality of life of patients and their families who are facing problems which are associated with life-threatening illness. It prevents and relieves suffering through the early identification, the correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. So physical symptoms would be like pain. So palliative care aids to relieve pain, manage other symptoms, thereby mitigating discomfort. The psychosocial domain would be to provide emotional and mental support and to help the patient fulfill their goals and desires. The spiritual part would be to empower the patient and to help them finding purpose in their condition. So palliative care cannot be given alone. Palliative care can be only given successfully as a team approach. So palliative care is a low-tech, high-touch approach. So it would include a neurologist, a palliative care physician, nurse, physiotherapist, speech and occupational therapist, dietitian, psychologist, social worker. Coordination of services is very important in palliative care to improve outcome. Now we'll talk about the palliative care models. So there are 3 models. Traditionally, palliative care would come in only just before the death of the patient. So as you can see on the left side of your screen, the blue block is so long. That is the time when neurological and medical specialties are treating the patient. And when they reach a stage that they can help them that they cannot help them anymore, the patient is shifted to palliative care. So the minute they're shifted to palliative care, within a shorter duration, the patients are faced with death. The dying process starts. So what is the problem with this traditional model is that the patient and the families are used to the parent team of doctors. They are very familiar with them. And suddenly, when things change, they are thrown into the palliative care side where every phase is a new phase for them. The second model of early and increasing involvement of specialist palliative care services, we can see that palliative care starts at the time of diagnosis, but it's a small rim of palliative care. The majority of the treatment is delivered by the neurological and medical specialties, but palliative care is a very small component which progressively increases and to have a major component just before the death. So there is a seamless transition of care here from the neurological and medical specialties to the palliative care. Now, the most recent model of dynamic involvement of specialist palliative services, which is based on trigger points. So we can see that whenever there is an acute exacerbation of symptoms, palliative care comes in to settle the trigger points. So it is involved from the diagnosis till the death whenever there is an exacerbation or trigger points. So what are the goals of palliative care in ALS? The first and the foremost one is to enhance the quality of life. So whatever the quantity is, but whatever the time they have, they should have the best quality of life. That is the main aim of palliative care. The second would be to relieve suffering, be it physical, psychological, or spiritual. Palliative care also helps in supporting the decision making by the patient and the relatives. And other goal is to coordinate the multidisciplinary care, that is to get everybody involved in treating the patient as a whole. Palliative care also provides support to caregivers. Now, timing of palliative care. When should it begin? It should begin at diagnosis, and throughout the disease progress, it should offer ongoing support, and it is very crucial during the advanced stages and during the end of life care. So symptom management in ALS, palliative care takes up care of all the physical symptoms, namely dyspnea, pain and cramps, siluria, dysphagia, and spasticity. I will not go into the details of each and every symptom management because there are other speakers who are going to speak to you in depth about each symptom management. Respiratory support, non-invasive ventilation can be considered, but this discussion should start very early in the course of disease. Clearance of secretions can be done using suction or cough assist. Oxygen should be used with caution in these people because of the risk of carbon dioxide retention. And discussions about the tracheostomy, when the need arises, should be done much before in the course of the disease. Communication challenges do happen in ALS because of the progressive dysarthria and anarthria. Speech therapy can be considered for voice conservation. AAC, which are augmentative and alternative communication devices, are used for overcoming the communication challenges. Eye gaze and text-to-speech technologies have been used nowadays for overcoming these challenges associated with communication. Nutrition and hydration. So early dietary support is very important. It should happen much before the weight loss. So it is a preventive measure to avoid weight loss. Assessment of swallow should be done, and factors which can help in improving the swallowing should be looked into. Percutaneous endoscopic gastrostomy should be considered before the FVC is less than 50%. You don't wait for the vital capacity to go down below 50% and think about PEG. End of life feeding decisions, that also needs to be taken, whether the patient or the family members, they want an inch tube put in during end of life care. All that needs to be discussed much in advance. Psychological and emotional support. All these patients usually they do confront depression, anxiety, and the fear of death. So counseling plays an important role, and antidepressants also need to be prescribed for these patients, which will definitely improve the quality of life. Support for the caregivers, not only the patient, the caregivers' fatigue needs to be prevented by giving them support or respite. And we need to help them facilitate with coping and adaptation to the new normal. Advanced care planning. All these issues should be discussed early regarding the prognosis, the ventilation, and the feeding requirements. Advanced directives and living wills should be in place, and appointment of a surrogate decision maker for the patient should also be considered. And over everything, respecting patient autonomy and choices are very important. End-of-life care. So end-of-life care would include symptom control, mainly breathlessness, agitation, and panic attacks. Sedation can be considered if needed. Usually we use midazolam subcutaneous infusion, or subcutaneous midazolam, which can be repeated every 6 to 8 hours. Emotional and spiritual support. And bereavement care for the family. Even after the death of the patient, the family's emotional, psychological, spiritual support needs to be taken care of. What are the challenges and barriers in palliative care in ALS? Even today, late referral to palliative care is a major challenge. So as we discussed, palliative care should start on the day of diagnosis. And there is limited awareness among the health providers also regarding the role of palliative care. There are ethical issues around assisted dying. And we also have to address, because caregiver burden and burnout is not actually addressed till date. So to conclude, palliative care is integral to ALS management. Palliative care improves quality of life and decision-making. It requires early and ongoing multidisciplinary collaboration. Thank you.